everyone, welcome to CTSNet. We are here at IATS 2025 in Copenhagen, and I'm here surrounded by this incredible panel for endoscopic, minimally invasive, and robotic surgery. This is the steering committee from the Endoscopic Cardiac Surgery Club. So we have Marco Solinas, Joseph Zacharias, Mattia Glauber, Patrick Perier, Piotr Suwalski, and Mario Castillo-Sang. So today we are just welcome to this roundtable about minimally invasive endoscopic and robotic surgery. The idea is that you can discuss, I have seen you discuss like friends, you are actually friends. The idea is to go through history, like starting through history of the techniques and a little history about the endoscopic club.
Sure.
So go ahead, please. Thank you for coming.
Joe?
Well,
Thank you, Lorena, for having all of us. So it's quite interesting that the history of Endoscopic Cardiac Surgery Club starts in the middle of the pandemic of COVID. And we were all at home. I was having COVID, and we were probably all at home more than normal. And we started communicating on email about whether we should create a focus group that discusses how to create an awareness for endoscopic cardiac surgery. As you know, it's not new. Hugo Bannerman had pioneered it nearly 20 plus years ago. Chitwood, Moore, all of them had created the element of body of evidence that we were using. But every time I was at a meeting, people would say things like, only a few people can do it. It's very special. Nobody else can do it. It won't catch on. And so we started communicating, and what surprised all of us, maybe because we had more time than usual, was that we all were very keen, and many of our first meetings were just on a web sort of Zoom. Fortunately, we all created this group that we eventually called the club. Personally, I didn't like the term club, but that we have to blame Patrick for, because he wanted to give homage to Le Club Mitral. And so we decided to call it the ECS Club, and it was based in the UK, and all of us sort of communicated and started to set the process up. And we were very fortunate that we had a lot of industry support. So we set it up as an independent, not-for-profit group that we would set up and gradually work. And of course, we have been very fortunate to have young blood like Mario and Piotr joining us over the last few years, and it has really brought a lot more energy, and we're so excited that someone like yourself and CTSNet is also starting to sort of get interested in our work.
Yeah, I would like to say that we're missing Jörg Kempfert from Berlin, and we're missing Antonio Spitzis from Thessaloniki. They're part of the steering committee, also founding members, and they can't be here right now.
And Sam
Balki from Chicago. Sam, sorry.
Yeah, by the way, to say that going back to the name club was obviously used because of this, let's say, legacy with the mitral club, but also because of the meaning, because we want to create a group of friends, a group of people without any professor or any, let's say, title or big mentor. We want just to share with other surgeons, other friends, our knowledge, what we have achieved in many years of, let's say, pain, because in the early beginning was a little bit a pain, and try to convince them that was feasible, that they don't have to go through all the steps that we have already done.
So these steps are, I'm sorry just to cut you, but I wanted to know if these steps were to be minimally invasive and then cross to endoscopic.
But I mean, the one that I think that can answer to that is Patrick. Patrick is a pioneer in this, is the one that inspired most of us. So I think that, Patrick, you have to answer to that.
Yeah, I've been inspired as well. I think it was in 1999. I went in Alps to see Hugo van Hermen, and he was using his endoscope. And I said to myself, this is the way. I had no idea how an endoscope would work and so on. But we started in 2000. And at that time, when you started, you were just alone and you had no mentors and you had no things. So you had to discover and you had to suffer and you had to think, but it is the way. And it's fascinating. It's fascinating how the field has evolved in the past 25 years, and it's going to evolve. And this is the great thing.
Yeah.
So you all started doing mini and then went to endoscopic.
I think everybody here started that way, right? I mean, everybody started with
Direct vision.
Video.
Direct
Direct vision, then
or
video.
direct vision. One of the two.
How was this path, this change? How did you cross from this technique to the other?
Well, it was quite natural, I would say, because you start to have the scope in the field that at the beginning is just an expensive light, but little by little you see that you can see corners that you can do with your direct vision. You can explore from an anatomical point of view the heart and the chest. And so little by little you get this feeling that you see better, that you can do better. So you start to put 1 stitch, 2 stitch, 3 stitch, and then you discover that you can do the all, and you cannot go back. I mean, sometimes when I'm forced to do some sternotomy for other reason, I feel quite uncomfortable because I lose. Now, I mean, I don't want to say that I lose my confidence or my comfort zone when I go through sternotomy, but it's really a bad feeling, a bad sensation that I cannot see what I can do with the scope. I know this was my...
You definitely find a position of comfort with the scope. Once that, it doesn't matter the body habitus of the patient, once the camera goes in, okay, now we're doing the surgery.
I think that there are some important things to know. Is that the first thing is that your decision at the beginning, and this is how I at least it was like this for me. I wanted to go endoscopic, but I had to start to do direct vision. The transition, it's not a transition, it's very abrupt to go from sternotomy to minimally invasive direct vision is very abrupt, it's brutal, it's from one day to the other. But then the transition between direct vision and totally endoscopic is very smooth because you control everything. And so you can go at your pace, as Marco said, you go little by little, and then one day you recognize that, okay, I can do it.
There is one more thing to it. I have also a very kind of personal approach to this transition because at some point I have for a few years really bad problems with my back. And then when I found it that I can actually sit or just do actually and have my body in a normal natural position, just look into the monitor while moving my head inside the chest, it really helped a lot. Actually, it saved my life, and I till today, as actually Joe showed beautifully during your talk today, I think it's actually very important because lots of surgeons suffer from after years of bending over the table, things like this. And technology, I think. Also the 3D or even better quality of vision really.
The real driver for me was at a certain point to don't use anymore the rib retractor. So to work only with a soft tissue. Yeah. And once you use a soft tissue, it doesn't matter if you do an incision of 3 or 4 or 5 centimeters. So it's a soft tissue that creates your hole. Mm-hmm. And when you understand that the dimension of the hole and the use of the camera does not impact on your job, that's done. So you have achieved your totally endoscopic approach.
The question that I had for the group is, what do you feel were pivotal moments in adopting this that pushed you or gave you an edge to finalize your conversion into endoscopic? Whether instruments or myocardial protection strategies or scope, what would you rank them like?
I mean, if I was to answer it, I think Patrick mentioned it. It has to be in your mind that you want to go endoscopic. And if you believe that you want to go endoscopic, it is a process. Now, if it's in your mind that you don't want to go endoscopic, there is no reason to bring the endoscope. It'll be an extra hole. It'll be something coming in the way. You have lots of reasons why you shouldn't put an endoscope in. And so the point I try to make is, in orthopedics, they've gone arthroscopic. In general surgery, they've gone laparoscopic. In thoracic surgery, they've gone thoracoscopic. What is so different about cardiac surgery? Why do we have to stop at transaxillary for existence? It is a process. It is a process of moving. So for me, I've done a fellowship with Hugo. I've watched him do endoscopic. And for many years, I felt a bit kind of guilty. It was like a bit of Catholic guilt that I wasn't doing fully endoscopic. And I used to always look through the hole once in a while and put a retractor if I was struggling. And I spoke to Patrick and he said, it's okay. It's a transition. Don't worry. Don't be bad. Don't be upset. It'll happen. And his point was, one day you look at the screen, you look at the hole, and you'll think, why am I looking through the hole? And that day happens at different times for different people.
Exactly.
But my worry is it'll never happen if the scope is not there. And so I think it is important to have that belief right at the start that the journey is endoscopic. Maybe you do direct vision as part of the journey.
Well, I have to say that absolutely, I'm completely agree with that. I think that for me, and we start with Mattia together in more or less in 2000, so 25 years ago, more or less. I think that the first really important thing that we realized that to go minimally invasive at the beginning and then endoscopic, that is the natural, let's say, evolution of that, is that you do a better job for the patient. You are doing something good for the patient. So at the early beginning, what as mentioned before, Joe in his lecture, you transfer the pain from the patient to the surgeon, because at the early beginning was a pain, because there were no mentor. And also all the technical instruments and cannulas and devices and prostheses that we have now, that doesn't exist. The first move is to be convinced that you are doing something good for the patient. And then, so you are going to evolve yourself as a human being, as a surgeon, because you want to do something better. And the other, let's say, pray that I can do, that as a surgical community, I don't know why, but cardiac surgeon, we are so reluctant to embrace new technologies. That is one of the big mistakes that we have done in the last, let's say, 40, 30 years. Probably in the last 20 more than is more evident. But the technology, if it's a good technology, can just help. So if you can use a device that helps you to reach the goal, and the goal is to do a better job for the patient, just take it. Take advance from technologies, what we have done. So before there was a 2D scope, then the 3D scope, and now we have different needle holders. We have new prostheses that can fit in our incision. There is the robot, and Piotr can comment on that. That is just a very sophisticated instrument that if you can, if you have the possibility, at least you can explore. So stay tuned with the technology, embrace the technology if you believe it, that can really help you, and try to do the better thing for your patient. That's the only way why you are a surgeon.
I think it would be good there was a question in the previous session that I think was a very poignant question that we get asked all the time. And I think Piotr and Joe have a good answer for this. When one, when the other, talking about endoscopic, handheld, or endoscopic, robotic.
Piotr, you want to go first because you do it, and I could say...
But you use a beautiful metaphor for this. I loved it.
I love the metaphor. That's true.
I'm getting to the age where I've already forgotten my metaphor. But
About chefs.
Your chefs, okay, yes. No, I think, and Lorena, I do want to make a point before we move on, that your viewership should not believe, listening to our journey, that an important step is direct vision to move to endoscopic. because increasingly, like general surgeons and orthopedic surgeons, thoracic surgeons, today, Mattia, Marco, all of us are trainees who go straight to endoscopic surgery. So it is possible.
Yes.
You don't have to repeat our journey.
Sure.
And so it is important that that is an option, but you have to go to a high volume center and learn. So
That was just next. That was just the next. The next topic was about training directly.
Yeah, and once a surgeon is happy with an endoscope, do they want to get a robot? If you have access to the robot, if there is a robot in the hospital and it is available for a day or two, I'm sure, like in thoracic surgery, I do thoracic surgery, mediastinal tumors, very hard to do endoscopic, but very easy to do robotic. Mammary harvesting, very easy to do robotic, very difficult to do endoscopic. So there will be horses for courses, as Piotr mentioned. And I think my metaphor about chefs has always been the case where you come to a meeting like this and you see something working in Copenhagen, but it may not work in Blackpool. And I don't know how it will work in, Latin America, because we all have so many pressures. In the morning you go, you have cost pressures, staff pressures, various anatomical situations. So we have to learn to thrive in our environment. And so we as a group have nothing against robotics, but we worry that most of cardiac surgery may not be able to do robotics. There will be a proportion, and I think one of the dangers we find a lot of cardiac surgeons, and I think that's where you said we're not very good at adopting technology, is we always believe it's 0 or 100. But the world is all about, market share. Today, sternotomy market share, I would say, is about 90% worldwide. And endoscopic is probably 10 to 15% in different countries. I think Italy and Germany are leaders, but certainly the UK, we're certainly less than 5% endoscopic. But I believe eventually, I hope it'll be about 40 to 50%. And I think about 10 to 20% of that will be robotic, for sure. And that will be how it will develop together.
Yeah, that's interesting what you just said, because actually in Europe we have a completely different horizon of minimally invasiveness in general. In the US, you have either robotic or sternotomy, and that's why we are so happy that you hosted the club in Cincinnati, because we could also hold the torch of endoscopic surgery. And we were very happy to have lots of interest in this from the US community. Yes. In Europe, it's different because it's mainly minimally invasive and endoscopic, of course, sternotomy, and much less, especially now because of the MDR regulations, much less robotic. But I think it will, of course, change. It will fluctuate also according to the regulations, to the new technologies. But I think the central thing about the club is the endoscope. So and this is all about it. And as Marco mentioned, it's a tool, and Joe, it's a tool. It's a nice tool of endoscopic surgery. And if we have still like 10% of saturation of minimally invasive procedures, this and there, actually this is the discussion about whether use this or that tool is very secondary, because our mission is and the mission of the club is to recommend, is to kind of increase the saturation of minimally invasiveness in cardiac surgery in general.
So it's very important what you mentioned. I'm from Latin America, Mario also, and of course all middle and low-income countries can relate a little bit. But I have seen increasing surgeons doing increasingly minimally invasive. But because of the cost, not with the right instruments, but what you have in hand. And in that terms, when you are in a middle or low-income country, you can find any tool and try, and you will actually get it done. So in those terms, what do you think it's totally necessary to have a program or to start a program?
Yeah, no, that's a good point. So I suppose the cheapest move is hemisternotomy, because you use the same instruments and you can use the same instruments. But we have done randomized trials in the UK and shown that it doesn't make a difference to the patient, apart from the cosmetic benefit. If you want to make a difference to the patient, you have to go away from the sternum. So you have to do either a mini thoracotomy or ideally a non-rib spreading mini thoracotomy. Unfortunately, for that approach, you do need specialized instruments. So, I don't think we should say, how can you use old instruments to do this? We, as a club and as industry and as societies, EAC, CTSNet, we should support people. We had a very good presentation at Cincinnati about somebody who was buying instruments on eBay.
Yeah, from Argentina.
eBay. We should be able to support that.
Yes.
We should help.
Actually, that was, now that you mention, that was very interesting because his presentation about how he did all his way to the first endoscopic aortic valve in Argentina was just before from the Japan presentation. And he had to buy his instruments by Amazon. And they were like cheap instruments. But this is the way he started. And he did it, as I said, in Latin America, you will get it done in one way or another. But then the Japanese surgeon actually told us about he was getting paid more if he did it endoscopically.
Correct.
Because it was like they were trying to increase it, so they will pay him more to make it like more numbers.
Exactly, and that speaks to the benefit to the patient. In the U.S., I think that it's very clear worldwide that it's shorter length of stay, less transfusions, less pain. That's well established. Equal stroke mortality is the same or better. So I think that is well established. For both robotic and endoscopic surgery, it is. The thing is, the economical benefits to healthcare systems of doing an operation like this, where the patient likely gets the breathing tube out in the operating room, goes home in a short period of time, less readmissions, all these things impact. Joe talked about that in his talk a few moments ago. That is what creates the differentiator in the eyes of the government, the payer, to increase the pay. In Japan, they've recognized that. In the US, it's still not recognized. It is labeled differently. This is not minimally invasive mitral surgery. There is a code for endoscopic mitral surgery, but it does not reimburse more. So you see, when I guess the lobbyists or whoever affects Medicare, Medicaid, to show them that this improves the outcome for the patient, it will translate eventually into perhaps a slightly higher payment, and that will in turn change the appetite of hospital systems and surgeons to pursue training, to pursue getting into endoscopy.
Yeah, they are encouraged to.
Yeah.
What about in robotics? Because of course, when you think robotics, it's costly. It's costly, the instruments are costly, the robot is costly, and then they're not like super durable instruments. You have to change them, right?
Yeah, that's right. But these are of course valid questions. But I always at least try to answer this by some anecdotes. Because I remember it was 2005 and there was at that time ISMICS meeting in New York, and some guru from Wall Street was invited to have a keynote lecture. And after that he showed, all these magic things about the curves and everything. And then there was the question from one of our giants in cardiac surgery: why does the industry has so little interest in investing in cardiac surgery comparing to cardiology? And he said it's very easy, because you are too cheap. This is paradoxical. The point of view of the industry or business-wise can be different, because if we try to save one or two sutures $10 each, it's not the way. Actually, I wouldn't be in the long term afraid of introducing high technology in cardiac surgery, because it comes back. But of course, in a single particular cases, there has to be some investment. But on the other hand, look at this: how much is a percutaneous mitral valve?
Yes,
it's 20 times more.
You come back to the point of reimbursement. So
exactly.
These are procedures that are reimbursed in a different way. Cardiac surgery is now not anymore, let's say, reimbursed. It's much more cheaper for the healthcare system.
Yeah.
but it may be an advantage today with the economic focus. So it may be, because one of the things I always say is we're always told to work in a heart team, but it is very odd that in a heart team, one person's getting paid differently to another person. So I always say, how about just getting paid for mitral regurgitation?
Exactly.
And let's figure out the cheapest way to fix it. Instead of getting paid for mitral surgery and transcatheter are separate payments, which then produces some amount of tension between, everybody about which one to do, because there's different reimbursement. So if you're as a team, maybe we should be paid as a team.
In some hospitals, like in Germany for sure, you have so-called a common budget. And then you will see, because you have to also find the cheapest and the most efficacious method to treat a particular disease. And then you see that actually heart teams work differently. And the same, we were lucky to have this reimbursement in Poland for endoscopic cardiac surgery. But we actually did it also through calculation of the community societal advantages, like professional activity, for example. Because for the government,
going back a little bit to your question, I think that someone that want to start and have not, let's say, a real budget, I think that nowadays a scope is present in every hospital because of other specialties. And probably at the early beginning, the scope is the most costly instruments that you need. So probably the scope is already in the hospital. So the things that we have to achieve are instruments, surgical instruments, that nowadays are not so expensive like in the past. I think that also for someone that have not the fortune to live in Germany or in the US or in Europe, there is the chance to start from probably not, the most, let's say, expensive or new technologies, but you have in your hospital more or less all the things that you need to start. And probably the first investment could be quite cheap. And little by little, as Mario said, the administration will see that it's going to save money and probably starting to invest a little bit more on your specialty.
What about the training for people that are already, there's surgeons that are probably senior surgeons or in the middle, not junior. So going to do a fellow for 1 or 2 years is not in the table. What about that? What would you recommend?
So you have two options. You have two options. Or you engage a doctor for 1-2 years in your center, you pay him as a football player, and you are sure that you will obtain the best result because he is able to, recreate similar results, good outcomes. But this is obviously not ethical and not politically correct. Cost of education is probably much more, or it's higher than buying 1 or 2 sets of instruments that now you can buy with 20,000-30,000 euro. So sending one person with a salary for 1 year somewhere else is a real investment that you need to do. Or you pay a doctor that comes 3, 4, 5 times for rising the level of experience. So that can be the most, in my opinion, the most expensive investment. But to do this investment, you really have to believe and you have to be committed to start this kind of program. Coming back to the robot, I have a robot in my institution. I have it in the corridor in front of my OR. But if I ask my administration, which is a private hospital where every public patient has access, they tell me you can use it, but you use it only on private patients. And this, I think, it's not fear. So I cannot, or I don't want to do my learning curve in robotic on private patients, even with the experience of probably thousands of mitral repairs. As you said, we need to bring interest from industry again back to cardiac surgery. We have to support industry in using even probably more expensive devices. It's something where we can probably ask industry, but they now have the budget oriented somewhere else where the money comes back in a different way.
Does anyone has something different about the different ideas on the training? Yeah.
I do, and I think and every individual is going to have a different pathway. But I can give an example. This person we're talking about from Argentina, Matthias, who had never done minimally invasive surgery, never, only sternotomies. He spent a month observing surgery, doing dry lab work, and after that month, he procured the instruments, and did his first case. Now, I would have said, let's proctor you for the first case, but that remoteness did not have it. But we did talk about the case ahead of time. We talked about what things to expect, plan ahead, and he delivered the case beautifully. And now, since he has done many. So is he an outlier? I don't think he's an outlier. I have also seen it again in others that go and adopt, and with the right mentorship, they can do it. That's one way. The other way is through the club, we have, talking about instruments now, is we've asked industry, instrument manufacturers to help those who are ready to take that leap and have a case or two or three and are of great promise from a technical standpoint, to support them with giving them loaner trays. So they can do their first 2 cases or 3 cases as a loaner tray. And then they can prove to their administrators, look, this works. Let's invest in them. And then they buy the instruments.
Yes, training for sure is one of our, let's say, major commitment. And obviously the club has already provide some fellowships, and we are trying to improve the numbers of fellowship that have proven to work. As Mario say, I had also a couple of people that start their program in their own countries, but I mean, we have to, as a club, we have to work in a much more deep, let's say, way, because obviously we can offer 10, 20, 30 fellowship, but it is not going to cover the needs, because now if you talk with a young surgeon, you can see the need. They want to go endoscopically. There is a need. And to go there, the only thing is to try to do the endoscopic surgery a part of the training at the medical school. So we have to try, little by little, obviously, to go there. The people, as you make your rotation in pediatrics, you do your rotation for transplant, you have to do your rotation for endoscopic, because this is the only way to really engage the vast majority of the new surgeons. Because, I mean, I'm very happy that a senior surgeon embrace endoscopy, but okay, great. But the things that we want to do is to teach the new generation. It's the only way in which this wave can really have an impact.
So including endoscopic and robotic in the pensum of the fellows. That's okay.
And just to let Lorena know, when we advertised our fellowship, we only had funding for 10. We had 96 applicants.
96?
Yeah. So we doubled it. I think we gave 18. We put some of our money. So there is a lot of demand. But I think I'm going to try and mention one thing that Hugo used to say 25 years ago when I trained with him. He used to say there is no shortage of young surgeons wanting to do it. there's a huge shortage of senior surgeons who will allow them to.
Yes.
And I think this is still the problem. We do have a big cultural change that has to happen where the senior surgeon doesn't have to do it. He doesn't have to do transplant, dissection, endoscopic and robotic. He can be the chief, but he can have somebody doing endoscopic, somebody doing transplant, somebody doing dissection, and he be the chief of the unit. But unfortunately, there's still a lot of mindset where the chief wants to do everything. Yes. And sometimes that has held endoscopic back, I feel, because sometimes it's not that they don't have the skill, but they may not have the time and the patience and the 10,000 hours that Mario said to start and do. Well, they could easily send a young fellow to do that somewhere and bring him back and offer it in that institution. So my own view is cardiac surgeons need to more work like lawyers, where we have specialists in certain aspects of law, or even like orthopedic surgeons. I mean, orthopedic surgeons now are shoulder specialists, hip specialists, knee specialists, and maybe we should have mitral specialists, aortic specialists, etc. So we're going that way.
It's going that way.
That will hopefully help endoscopic.
But I think for endoscopic, I think that there is a fear for people who haven't tried or are not committed to of having some nightmares and not being able to control them.
Right.
And
I think Antonio Spitzis talked about it in his talk about having that mentorship is that person that tells you that is not a good case for you right now. And then the personal aspect of it is having the humility to say, you're right. Right? And so that's where it's at. It's an important aspect of, in any endeavor, of recognizing your own limits, your team's limits, and that mentorship.
The other fear is the time. The time of course, cardiac surgery has a lot to do with time because we are on pump, we are ischemic, so the time. And of course, everyone talks about learning curves and there's numbers. And do you have a number like between?
Sure, there's a number. German papers. I think Leipzig and Berlin have published on this too, right?
So I think there are papers showing numbers, but then those are not the papers that show trainees who have trained in high volume centers. So when Leipzig published that paper about 150 patients, I kind of thought that was not my learning curve. I didn't need 150 patients. So when I looked at my learning curve, there wasn't an obvious learning curve. Of course, the cross-contact bypass time along, and it wasn't because I was special anyway, but I did a fellowship. And so then when I looked at other people who've done fellowships, they didn't have learning curves either. And you published on it. And there's a very good surgeon in Belgium who's published on it. So if you do a 6-month fellowship or 1-year fellowship, you can get rid of the learning curve. Because the learning curve is not a number, it's a competency. So if you, as you say, learn which ones not to avoid, which ones to not start with, and that you learn as a fellow, you think, oh gosh, like I remember watching Hugo Venerman doing a 140 kilo patient, and I thought, this guy's done 1,000 patients and he's struggling with this patient. I'm not going to touch this sort of patient, at least for my first 200 patients. So you learn space, case selection, etc. as part of the fellowship. So I can't stress enough the importance of fellowship in either a high volume center or with a very good mentor who kind of translates. Because Hugo used to always say, I will tell you all my mistakes. You will make your own mistakes, but please don't repeat my mistakes. So, so when you talk about nightmares, I've seen all these guys have such bad nightmares. Thankfully, I've not had it. I've learned off them. So,
I love that session in Cincinnati. You had this session of nightmares and complications, and it was great to see because you were acting like real friends, like very supportive. Like, oh, I wouldn't be very happy in that case. What would you do? But no criticism at all, just support, which was very good to see in our field and very different, I have to say, from many meetings. So congratulations on that.
Thank you.
But at the same time, we have to always to understand that this is still surgery.
Of course.
So something can happen. And, there is the golden rule that is, it's not for endoscopic, but it's for all surgery, that if you fail to plan, to prepare, you are prepared to fail. So I feel that probably in endoscopic, this is a little bit much more important.
100%.
So also you have to develop as a surgeon a new mentality. Or you cannot go to the theater and ask to the nurse what is on the table. You have to know. You have to know what are you doing. You have to get a plan. You have to study the CT scan of the patient, the echo of the patient, and arrive in the theater with your program, your setup. Everything should be really a step-by-step surgery. You don't have to rush. You don't have to say, well, I cannot see the wire, I put the cannula. No, this is a big mistake. It's a growth, endoscopic is a growth as a surgeon, because you have to embrace different skills, different discipline, know how to read the CT scan now, how to make a percutaneous cannulation. You need new skills.
Why skills? Because nobody remembers that. You are your own camera person. You are your own camera person. I can't see that way. You move your camera. And people forget that. I see new learners, they can't see, and they're waiting for somebody else to move the camera for them. There's nobody to move it for you. You're moving it.
So now that we got to nightmares, so I think it would be very useful for our viewers to have these tips and tricks, like in rapid fire tips and tricks. So let's start with tips and tricks for cannulation, avoiding nightmares.
I think it starts with preoperative, like you said.
Okay, so preoperative.
CAT scan.
Yeah. CT scan.
What are you looking
to every patient?
We do to every patient.
What's your nightmare?
Aortic or mitral, everyone.
My nightmare is soft plaques.
Soft plaque, okay. In the descending aorta.
When I check the CT scan, I'm not scared about the white.
Yeah, the calcium.
What is calcium? It will stay there. But the gray, when you see gray, is not good.
Yeah.
You have to change your plan. So
does that lead you to? So what's your alternative? Antonio's talked about axillary cannulation.
Is what I do. And if nothing is available, I mean, you can change your plan. You can do a wider incision and put the cannula through the incision in the ascending aorta. I mean, obviously, you don't have to harm the patient. You have to adapt yourself. So you have many possibilities, but you have to know how to read the CT scan.
Okay. Joe?
Yeah, so the other thing I look at on a CT scan is what they call visceral fat.
Yes.
Because that'll catch you out sometimes. You're a slim guy, which is okay, but you go in and the pericardium is covered in fat.
Yes.
And the CT scan is good at showing that. You just need to have different instruments, like you showed the harmonic scalpel, or we use a ligature, which is cheaper, and you can get around it. But I think Mario's got an idea of us putting some videos on how to deal with it, because sometimes you can't see the pericardium. You can only see diaphragm and fat.
And you can imagine, you're starting your case, you put the camera, and there's no pericardium. You don't see phrenic, you don't see pericardium.
Can be quite
If you're starting
and deceptive sometimes.
Yes.
But I think cannulation is still the number one. You have to safe cannulation is the crucial aspect. And one thing I also want to mention for people who start is don't be obsessed with cross-clamp time and bypass time, because the forefathers of cardiac surgery have done a lot of work to make bypass safe and custodial and cardioplegia safe. So in the 1960s and 70s, speed mattered. Today, speed doesn't matter. You can take your time. And one of the things that the UK mini mitral showed was that the cross-clamp time and bypass time were longer, but the patient's going home at day 2. So it's bypass time and outcomes are not directly proportional.
They're not directly proportional.
So myocardial protection, tips and tricks for myocardial protection to avoid nightmares.
Obviously, our biggest problems we had in the past was related to myocardial protection. Either because the venous drainage was not good enough, so having a right fillet heart who was warming up the heart through the coronary sinus was giving us right ventricular failure, need for ECMOs. For having a good myocardial protection, we need first a good venous drainage. And for me, the best remains antegrade aortic cardioplegia infusion.
Which solution do you use, Mattia?
I use Del Nido. And since I'm using Del Nido, I never had again a problem of ECMO, right ventricular dysfunction, and so
And they come back in sinus, which is also with a rhythm, no ventricular fibrillation.
No need for defibrillation.
It comes with fibrillation.
Yeah. But I think the point that Mattia makes is very crucial. Vacuum-assisted venous drainage is more important than
the solution.
Because every time you look at a patient who has had a problem in another center, never mind, it is because the venous return has never been completely done. So many people are worried about vacuum assist, and vacuum assist is our friend.
And talking about the perfusion, I think if it's only possible, I think great tool coming actually not from minimally invasive surgeries, the GDP, so goal directed perfusion, when you can screen the DO2, so you can really, even if you go even up to 40% down with the flow, you still can monitor that you are on the safe side. So this is a great tool in our hands in terms of minimally invasive surgery and peripheral cannulation, I think.
What about clamping? Who wants to?
I'll start that one. Clamping, for me, the workhorse is aortic cross clamping. I use a CTSNet clamp. The Glauber clamp is also very good, and there's others that are detachable. But the idea here is that I'm not facile with Endoballoon, which is another tool that he can tell you more about. He can tell you more about.
What about Endoballoon?
So, I have this phrase, another metaphor, that the Endoballoon is like the Concorde of cardiac surgery. It is probably the cleverest piece of engineering that we have in our specialty. It is so clever that not many people can use it because there are so many channels, so many things. You show it to a perfusionist, they just go, what on earth is this? So I think as a tool it is very good, but it does need a stable team. It does need a very good perfusionist who understands what each channel does, what etc. You need a good anesthetist to show you where the balloon is, etc. Like yesterday you saw Sam's anesthetist, beautiful views. And so all of that is what you need before you start using the endoballoon. As cardiac surgeons, I often joke saying, I clamp, therefore I am. So we're all used to clamping. So we love clamping something. When we clamp something, we feel good. So the Glauber clamp, the CTSNet clamp, the Chitwood clamp, these are much easier. It's much easier for us to get our head around because we clamp and we know it's done. Well, the endo clamp can migrate forward, can migrate backward, can burst, can do all that. So you have to think differently. But it's like everything. It's a thought process. Once you get used to it, you get used to it.
Yeah.
I don't think the myocardial protection itself is different.
But I do think it's worth mentioning here, not for your first cases, but when you do endoscopic surgery, especially endoscopic surgery, not so much direct vision surgery, doing a beating heart or doing a fibrillatory arrest, it's almost as good. It's very good and it's very safe. And I think we all do that often, whether it's a redo or prohibitive aorta, very easy to do because you don't have to elevate that much, that left atrial septum with the retractor. Therefore, you don't cause that much aortic insufficiency, and the camera shows you everything.
What about the ports? Any trick of how to put them safely, how to start? Anyone?
I have to say something on the intraclude, but by the way, I'm so sorry. I'm so sorry about that because I go back to what we were saying before. Technology is our friend, and this is a very, as Joe said, a piece of engineering that can really help you a lot in different ways. For instance, in all the redos, to have the possibility to use the intraclude change your day. And so, it's not so difficult as could appear. It's quite easy if you start to use on a regular base. The only problem, and we go back to what we were saying before, it's expensive. In Italy, for instance, in which there is still some economical issues, you cannot use for every patient. So you begin and you try to stay trained to use this system because there are cases in which can really change your, let's say, your day, but change the outcome of the patient. So I'm open. I have this on my shelf, and I'm going to use it whenever is needed. Going back to the ports, I think also in this particular, it depends on the patient, on the anatomical feature of the patient. And it's something that you can really check on the CT scan. Now we have a lot also new tools coming about, virtual reality, in which you can really plan everything which you want to be your working port, your camera, your scope, and so on and so. It's something that you can plan in advance. Most of the time, let's say for 90% of the patient, your standard setup is going to work, and probably everyone have his own, but still is not a big issue. But the thing that you can plan in advance with the CT scan is probably the most easy way to do it correctly and have the most from the positioning. And to do it safely, is not a big deal, because most of the time you do the incision, and then if it's all clear, you go on bypass. So you take your lungs down, you put your port without any problem to injure the lung. So it's not a big issue.
So one thing I learned yesterday, and this is what I mean, you learn every day when you say, is from Sam. So I'm probably going to do what he does, which is
to
inflate with CO2.
To pressurize.
It pushes the diaphragm, pushes everything, and then putting your ports are so much easier, safer, because he was putting all the ports under visualization with 8 millimeters of CO2. And I think this is something I'll take back, even for endoscopic, even though you showed robotics. So yes, I think we're constantly evolving, but putting ports, you're right, is very important, because every intercostal artery or vein you hit, every reopening I've had is an intercostal vein or artery. And it is so annoying because you don't see it, it's heparinized, you think it'll stop, and it doesn't stop. So it is an important question.
There was a point that we haven't answered, is single lumen ventilation or double lumen ventilation. Any takers on that?
Yeah, so if I may, I will only say we started a few years ago a program of lung transplant, and I think I understood much more. I'm not sure if I really did, but at least I have the feeling that we should also remember that we have a bronchial circulation. This is actually, you are as a thoracic surgeon as well, you know much more than we do. One of those nightmares that we have is this single white lung syndrome. And still, I think what we try not to do is to ventilate one lung on pump, especially weaning off pump. Yes. I'm not sure if I'm right, but since we really stopped this,
you're right.
I haven't seen any white lung anymore. So I think this is at least a very important thing that I want to point out. Maybe
much more safe.
Yeah, so we use a normal bronchial.
Single lumen tube.
So
probably it's much more safe to spend 10 minutes more on CVP than to ventilate one lung.
Exactly, and it's safer.
And this comes back to a point that most people are obsessed with cross-clamp bypass time. So they want to come off bypass quickly. Most of us will spend that extra 10 minutes on bypass, making sure we got hemostasis, and then once we come off, we're gloves off. Yeah. But the initial surgeon will want to reduce the cross-clamp bypass time and come off bypass, and then have to deal with all the bleeding and go to one lung down, and sometimes that can be a costly expense. But I think after seeing this thing of insufflating CO2, I might also stop doing double lumen, because you can just insufflate CO2, the lung will go down on its own, and then the anesthetist doesn't have to do anything. So I've learned something yesterday.
I keep double lumen only for redo patients.
Yes. For some robotic you need this as well, but I think the point that you shouldn't, however you intubate, you shouldn't use one lung when weaning off bypass. Yes. I think this is very important, but I agree this is one of the instruments that you have double lumen if you need, like as you said.
Yes. Or just if I have to reopen the patient for bleeding.
Right. Yeah, absolutely. Absolutely.
We use a bronchial blocker. I don't know if you use bronchial blockers.
Doesn't like it.
What about the anesthesia or the, like the blockage? the pain management. That's
nothing for anesthesia. Nothing in my operating room. Anesthesia only puts the patient to sleep and gives the central line and an arterial line. Everything else happens on this side of the curtain.
and for pain control.
So I'm going to quote a thoracic surgery mentor of mine called Bill Walker. And he used to always say pain is not proportional to the incision length, but it's proportional to the width of spread. Mm-hmm. And what we have all found, as soon as you get rid of the metal spreader, pain becomes less of an issue. So if you go to a lot of the meetings where they're talking about cryo block and this block and that, they probably are spreading ribs. Because once you stop spreading ribs, day one is painful because sometimes the drains are painful, etc.
Yeah.
But by day 3, pain's gone. Yeah. Because once the tubes are out, etc. No local anesthetic we give lasts that long anyway. So you can give blocks, etc., which may help. But I think the key thing is not to spread the rib. And I think that's probably where robotics really excels because they don't have to spread the ribs.
In most cases. Some still spread the ribs.
Yeah.
But that's my own.
But you're completely right. Most of the pain comes, if you do a really endoscopic, comes from the drains.
Yeah, and it's not even sometimes it's between the ribs, but mostly it's when they take a deep breath. The drain itself in the pleura, right? It says referred pain, yes.
So bizarrely, there are options of cryoablation, etc. But you may find that none of us use it because we don't feel it's required. But that's not to say that it isn't available.
No. So believe it or not, we've been here for an hour.
Oh my God!
Yeah.
Those were quick 10 minutes.
It was. So I want actually to wrap this up with something about the perspectives. Where are we going with this? Where are the advancements? Innovation. Like one phrase, not one phrase, but something from each of you.
You go first.
Thank you. I think that for sure the next steps for me will be to integrate imaging in our theater. Try to be even more precise. Obviously, I'm sure that in the next year we will have a great improvement in terms of instruments, because the guys that are doing robotics, they are working a lot on instruments, and something will come also for us. We are going to have better instruments, we are going to have better scopes, for sure, but the thing that probably is the next step is to integrate all the data, all the information that we have in the theater on the patient, so to have a much more tailored procedure of that patient.
From my point of view, I think my biggest hope and my biggest wish, both as part of the club and CTSNet, is that we get this term endoscopic into cardiology literature. Because cardiologists claim they don't know what is possible. And every time you have a heart team discussion at lifetime management, if you offer an endoscopic approach, quite often the transcatheter guys will back off. But if you offer stenotomy, even the patient will go, even if they come, and even if the cardiologist says, okay, see the patient will go with transcatheter. So we really need to get endoscopic, robotic or non-robotic, into more heart teams. And unfortunately, because heart teams are smaller, we are trying to set up what we call heart networks, which are more than one heart team. So in cancer surgery, we work in heart cancer networks, because you can't have a cryo knife in every hospital, but you have it in one region and different people. And so I hope cardiac surgery and cardiology work more like oncology, and endoscopic, ROS, all these procedures are part of the network. And so we get into that place. So that's my hope for the future. As much as AI is exciting and all these things are exciting, I think the big problem is we are not being offered to patients who may benefit from it. And I hope that happens.
Mattia.
Very, very interesting comment, both. Surely the integration of imaging will help a lot in simulating the procedure. instrumentation, and I've seen some interesting projects in China where they're working to very friendly robotic procedures done not on a console but done at the patient, which is obviously a different way of thinking robotically. But where I see the real future is to integrate transcatheter in surgery, where the surgeon comes back to have the control of what was traditionally a surgical treatment. It will require probably some years, but it's where I see the future in the long term.
Thank you. So, Piotr.
Yeah, thank you. So maybe what crosses my mind listening to your question, first of all, it's more general scope. It's like I deeply believe there is a very big, what you sometimes call in a marketing section for endoscopic surgery. I'm happy to see young people asking me, because we had this discussion whether you should perform first 10,000 sternotomies and then switch to endoscopy.
10,000?
No, just referring to those 10,000 hours. But and then young people just ask me, why should I perform a procedure that is dying actually? So whether they are right or not, or why should I perform a procedure which is not the future? Maybe I should phrase it that way. For my future life. Yeah? So I'm not discrediting, of course, the sternotomy in general because this other, but I mean the approach of the young people. They really insist on learning something which is the future of their career. So this is one thing. Also, there is and will be big pressure, luckily, from the patients as well. Mm-hmm. This is already what we see. And then look at Germany. They already think about 60% of mitral valves are being done through any kind of minimally invasive approach. Also, I deeply believe in new technologies we already see the new video systems, new integrational systems, and also new tools, new instruments. Robots are coming. I'm happy that the market is really opening, which is always good. So I really believe in the future of endoscopic surgery.
Yeah.
Thank you.
I agree with everything that everybody has said, and I think it's incumbent upon entities like CTSNet, the Endoscopic Club, and the societies to create platforms to scale this up to the next generation. We're missing that. We don't have that yet. Platforms in which somebody can say, you know what, I've never seen a P3 repair. Where can I see it? And they can go and see a P3 repair, not that one way, 30 different ways by 50 different surgeons. And I think that's where, for me, that's my aspiration. That is my hope, is that we can create platforms where the young surgeons can go and learn things in their off time and reinforce what they will never see. When I was in training, one of my attendings said during his training, he saw 20 mitral valves. And that's what we see in less than a month today.
That's the whole idea with CTSNet.
Right.
You can go and check some videos, very interesting videos. By the way, so we will have the videos that were actually shown at the meeting, which are super interesting at CTSNet, so everyone can see how to do some things, how not to do it, and the instruments and the different procedures that you can perform. As you know, we are ongoing on an atlas, so everyone can see exactly what you said. Like, I want to see P3 from him, and you can find it. Thank you very much for being here for more than an hour. It really wasn't that long for me. And I hope everyone there will enjoy this and will learn a lot. For me, I learned a lot from this. So thank you very much to you all. And I hope to have you in another roundtable in the future. Thank you.
Thank you very
Thank
much.
you very much.
Thank you.
Thank you for
Thank
your
you. Bye.
interest.